Hello, everyone. Welcome to the IAOMS Stay Connected series. My name is Vinny Cavello, and I'm the marketing manager for IAOMS. On behalf of IAOMS, I want to say thank you for joining us today. Please note this session is being recorded for IAOMS educational use. Personal audio or visual recording of this program is prohibited. If at any time you experience technical issues, please utilize the chat feature within Zoom to directly connect with me. This chat feature will also be used for the Q&A portion of the program facilitated by today's moderators. I would like to briefly share some exciting opportunities with you before we begin today's program. Our final session of the IAOMS Stay Connected series is scheduled for Monday, June 8th. Registration for this session is now available. Please note that the following is the conclusion of today's program. Attendees can complete a brief survey to obtain a certificate of participation. This can be found through the e-learning platform under each program you have attended. IAOMS would also like to send our appreciation to all of those that have attended weekly over the last 5 weeks. We hope you've enjoyed connecting with us virtually during these uncertain times, and we look forward to our final program next week. Finally, we hope you join us on Friday, June 5th for the IAOMS virtual conference in collaboration with Osteoscience Foundation. Registration is complimentary thanks to the support of the Osteoscience Foundation, and this program features one keynote speaker followed by 3 concurrent breakout sessions. To learn more, visit iaoms.org under virtual conference. And now it is my pleasure to turn today's program over to our moderators.
Hi. I'm Barry Steinberg. For those of you who don't know me, and many don't, I'm a professor at the University of Florida College of Medicine, and I am the program director for the Pediatric Maxillofacial and Craniofacial Surgery Fellowship that we have here. And that's pretty much it.
Hello. Good morning, everyone. I'm Rodolfo Asensio. I'm from Guatemala. I'm professor in Centro Infantil de Estomatología. It's a hospital we do cleft lip, and we are in Guatemala. Welcome, everybody.
So I guess now we're ready to begin, and I will have the great pleasure of introducing someone who is internationally well known as an expert and speaker. One of the best that we could get here today. I think you're all going to enjoy his talk. It is Professor Kita Banataya, who is at the University of Bangalore. He wears many hats. He is a consultant for SmileTream. He is a professor of maxillofacial surgery at the University of Bangalore. And at the present time, he's the vice president of the board of the Directors of International Association of Orthodontic Facial Surgeons. It is with a great pleasure and honor and anticipation that I give you Professor Banataya.
Thank you, Professor Steinberg, for that kind introduction. I'm going to talk to you today on the management of cleft maxillary hypoplasia with anterior segmental distraction, and while I just connect my presentation here, just give me a second. Yeah, so basically this will be a presentation that comes out of the cleft palate team at the Bhagwan Mahavir Jain Hospital. Like you just now heard from Professor Steinberg, we are one of the partner hospitals with the New York-based NGO, the SmileTrain, and we have been so for about 15 years. We are a multidisciplinary cleft team that offers everything in one roof, starting from prenatal counseling to rhinoplasty when the child grows up, and we treat about 600 patients every year. India is a vast country, as some of you might know, of 1.2 billion people, and we do have about 35,000 children being born with cleft lip and palate deformities every year. SmileTrain has been a game changer in managing a lot of these children, not only in India, but many of the developing countries for the last 20 years now. So my remit today is to speak to you about one of the tools that we have in the management of cleft maxillary hypoplasia, which is segmental distraction. So just to put things in context, why cleft maxillary hypoplasia? It is sometimes controversial, but most of us do agree that it is the early scars of surgery. Whatever technique, whatever protocol you follow, that is probably the most important cause for retarding the growth of the maxilla as these children grow up. But there may be other features, including the genetics of the parents, some facial dysmorphology that is inherent in the disease and so on. But it's been clearly proven by studying adult unoperated cleft palates that it's mostly the scars of early surgery that contribute to this kind of a problem. If you look at various studies, the estimates vary from 30 to 60%. It also depends upon how the criteria with which you define cleft maxillary hypoplasia. If you go strictly by cephalometric norms or even clinical norms, you might get a higher figure, but oftentimes you will find that these are defined by the need to do a maxillary advancement, which is a slightly nebulous thing. Now, we could see this kind of a cleft maxillary hypoplasia developing even as the child is growing, and in the late deciduous dentition, early mixed dentition, or even little later in the later mixed dentition, depending upon what protocols you follow. Orthodontists may come in and do growth modulation to mitigate these early growth disturbances to some extent sometimes. So there are a number of techniques that are followed. We follow a maxillary protraction with a reverse headgear in the mixed dentition period around 7 to 8 years or little later on. And it is possible with this kind of a technique to overcome deformities to some extent, probably correct the deformity that exists at that point of time. But one of the problems with that is there's still more growth happening, particularly in the lower jaw, and you may not get a sustainable results. Today, there is more focus on doing this growth modulation at a little later age, say after 11 or 12 years, so that you could have a continuous care of orthodontics, which will spill over to surgical orthodontics if required. And one of the techniques that has gained popularity is the one that was popularized by Eric Klug, called the Ultramec technique. Now, if you have to do surgery, irrespective of what results you get with your growth modulation, oftentimes the growth modulation might reduce the magnitude of the deformity, if not correcting this, and that might make your surgical results that much easier to obtain, as well as maintain stability of. So all of us know today that broadly we can classify the surgical options into the older conventional orthodontic surgery and the newer tool of distraction osteogenesis. I will not, because of lack of time, go into the merits of doing each one of them. But if you decide to do distraction osteogenesis for whatever reasons, maybe it is the magnitude of the defect, maybe it is your proficiency with that, where you tend to jump onto this option much quicker. Whatever may be the reasons, there's once again a lot of discussion going on that, and we won't get into it right now. The options classically, when we started off in the late 20th century, early 21st, with some work that was done, was to advance the maxilla in the LIFO1 after the LIFO1 osteotomy, and that was the mainstay for many years. Today, there's another technique that has become quite popular in some parts of the world, including mine, where we just do a segmental osteotomy between the premolars, or between the second premolar and the first molar, and then advance only the anterior segmental maxilla in order to obtain results that can be optimal. So when we talk about the LIFO1 osteotomy, initially people started off by just doing the osteotomy and then distracting, as was the protocol with distraction osteogenesis. Soon found out that this is not going to work. So whether you're doing a conventional osteotomy or a distraction, you will end up doing the down fracture mobilization, and then you have a choice of coming out with external fixators like these. These were the ones probably popularized by Pauli and Figueroa, reporting at the end of the 20th century, the so-called rigid external device or RED devices. They were popular and are still being used when complex deformity correction of the midface has to be done. But because of obvious reasons, alternative kinds of fixators were developed in the years that succeeded. And then there was these internal distractors, principles being the same, where you did a complete LIFO1 osteotomy, down fracture, mobilization, and then fixed internal distractors to some obvious advantages and some disadvantages. Now, when you do an anterior segmental osteotomy and then distract, this is once again the technique that we use. The one that I'm going to talk about today is about using an intraoral tooth-bone Hyrax device. There may be various other modifications of these that have been used successfully around the world, but our experience is with doing the anterior segmental osteotomy using a Hyrax device intraorally. So you might get to see a number of papers on this, but early on with a significant number of case series, the work came out of Turkey, and basically this followed the principles of anterior segmental osteotomy, and then by doing a buccal approach, doing an interdental osteotomy between the two premolars, or the premolar and the first molar, and then distracting that as I indicated. So now that we know that we have a number of options in conventional orthognathic surgery, as well as different levels of osteotomy for the distraction osteogenesis, what are the indications for the use of this segmental distraction? One of the most important reasons why we do it regularly and continuously is to increase the length of the maxillary dental arch. So oftentimes you find that the arch is constricted anteroposteriorly or laterally, where there is crowding and not enough space for the teeth to align alongside a normal arch. Oftentimes you find that a number of teeth are missing, though there is no crowding, and the occlusal table is far less efficient than it should be. And this is something that is probably not possible to correct by doing a maxillary osteotomy at the LIFO1 level, because you're bringing the maxilla forward behind the last molar tooth. Whereas in this instance, you are creating a gap, or you're growing bone between the teeth, thereby you are able to increase the length or the perimeter of the arch to manage crowding, or to increase the occlusal table where a number of teeth are missing. The other controversial aspect of management of cleft maxillary hypoplasia is what happens to the speech. Once again, if you dig into the literature, you find a whole lot of conclusions that have been drawn from different studies, and it's so difficult to be sure. But there's always the lurking suspicion that when you advance maxilla, particularly the full maxilla, over significant amounts of sagittal movement, you might end up with a velopharyngeal dysfunction, which was hitherto not present. Particularly, there is some consensus that if the person had borderline velopharyngeal dysfunction, then there is a great likelihood that you might end up with a velopharyngeal dysfunction. Our experience of doing LIFO1 osteotomy is the same, that in a small percentage of patients, about 10 to 12, you find that this is not reversed after some time, which is what a number of people believe, that this kind of a deterioration of speech could be temporary, but in some instances, it persists and you may have to do a secondary speech surgery. And oftentimes you find that patients are not happy to sacrifice their reasonably good speech for better looks, and then when offered a maxillary osteotomy with the proviso that there could be a change in speech, that is often rejected. So if you have good speech or a borderline BPD where the patient is happy, because you're not moving the soft palate forwards, the likelihood of you risking a deterioration of speech is less. And this can also be used in relapse after conventional surgery. When we first started doing this, so we use this quite often to salvage cases where there has been a significant horizontal relapse after conventional surgery. If you refer to Professor Lim Chung's paper that came out in 2006 in the IJOMS, he quantified that there was at least 30% relapse horizontally in a meta-analysis of conventional orthodontic surgery that he did. The distraction protocol is very similar to whatever distraction you do in the CMF, latency of 5 days, rhythm of twice a day, rate of 1 millimeter, consolidation period of about 3 months or 12 weeks, because there are some papers that suggest that if you do a shorter period of consolidation, you might end up in greater degree of relapse. If you remember, Ilizarow's recommendation after basics research on distraction was to keep the fixator for 2 to 2.5 times the time that it took us to distract, but that may not be adequate. So 10 to 12 weeks would be the time that we keep the distractor on. The advantage is, as I said, the soft palate stays put. You do not use an extraoral device as the RED. It's easy to perform, and coming from where I do, working with the kind of patients I do, it's extremely cost effective, and that is something that pushes us to carry out more of these procedures. One of the significant limitations of this tooth-borne Hyrax device in distracting the maxilla is that this is the vector is unidirectional, and also oftentimes there could be a tendency for a counterclockwise rotation as the maxilla is advanced, giving rise to an open bite. So control of the vector is a little difficult, and that is unidirectional. That is something that you need to remember if you're going to use this technique. I will look at a typical case of maxillary hypoplasia and how we do this anterior maxillary distraction under these headings as we go along. So the most important one is case selection. This is something which is a learning curve. This is one of the early cases where the negative overjet was about 20 millimeter or minus 20 millimeter. With so much of crowding there, the arch is constricted in all dimensions, and it's a nightmare for the orthodontist to think of aligning teeth here. So these are the kind of cases, and the other indications I've already mentioned. The basic workup we would do is just like any other case of orthodontic surgery or distraction. But one important difference is that in order to safely do your interdental osteotomy, you would ask your orthodontist to open up a little space, even though today you have finer devices, a little space between the two teeth where you do the interdental osteotomy so that you don't damage those teeth, like you see in this figure. And our orthodontists like to use a rectangular wire in order to stabilize whatever results they have got pre-surgically, because during distraction, these teeth can go haywire once again, as I will show you in another example. And so these Hyrax appliances are customized by our orthodontist for the individual patients on their cast just before the surgery. That is how you see a customized Hyrax appliance for a given patient that has been prepared on the model and soldered. And currently what we do is to cement this Hyrax pre-operatively. When we started doing it, we used to cement this Hyrax on the table after doing the osteotomy. But today we find it much easier to fix this before surgery and then carry out the osteotomy. So the osteotomy will be with a labial incision going around from the piriform rim to to the anterior teeth, and then a vertical incision at the area of interdental osteotomy. Carry out, and the blood supply being palatal here. Do your osteotomy as marked there. A horizontal limb from the piriform rim and a vertical rim at the site of the interdental osteotomy. You could use a piezo today to very neatly do these interdental osteotomies, though we started off by using osteotomes before we could get access to these instruments. And once you've done your osteotomy cuts, you want to make sure that the anterior segment can be mobilized, that your osteotomy cuts are completed, for the simple reason that oftentimes these cuts may be blind on the palatal side, and if you're not sure whether you have done the osteotomy, then you're going to rue your decision of not checking that. So like in any other case of distraction, you would go ahead and move the segment on the table front and back, and then wait for a period of 5 days of latency period, after which you start doing about 0.5 millimeter twice a day. So that mounts to the hyraxes that we use to 3/4 turns twice a day. I will now go through some of the case series that we have done, and also a few complications in the time available. We have used it in mild, moderate, and severe deformities based on the indications that I've already mentioned. She's one of our first cases. We started doing this about 8 or 10 years ago now, and you can get results like that over a period of time. She's one who had crowding. The orthodontist had done some amount of pre-surgical aligning, etc. He removed those wires. This was our first case, as I said. And while we were distracting, the teeth started moving all over the place from where they had come. We had learnt our lessons, and that's when they started using these. That's when they started using this rectangular wire to hold that anterior segment in place. So once you have done this distraction, you can very nicely move the teeth around and get a good arch, as I will show you in a couple of other pictures. And then you might do a rhinoplasty or whatever else that is required later on. In the case of a bilateral cleft lip, where once again there was a mild deformity, that is pre and post the distraction and rhinoplasty that you see the lateral views of. And these are the intraoral views. You find that sometimes you will find that there is crowding and at the same time many teeth missing. One of the advantages of doing an alveolar distraction or a segmental distraction is that in the new bone, you can add on teeth. The best obviously are implants. So there are instances where you can add on 1 or 2 implants, implant supported teeth on either side of the distracted area in order to get a better occlusal tape. So that's him pre-post after rhinoplasty. You could use it in milder deformities like this as well in improving profile. Now I come back to this case. He's the one who had minus 20 millimeters of overjet. We enthusiastically started doing this and made some mistakes with him, but learned a lot of lessons as well. We could move him forward by about 10 or 12 millimeters, but he still had a significant defect remaining. The plan here was to use the hyrax a second time. So these hyrax that are available in our country allow about 13 millimeters of movement, and you don't get one-to-one skeletal movement as you open up the screw. And in this case, the plan was to resite it, but it did not work, and then we had to go back and operate on him. But by then, again, by conventional orthognathic surgery, however, with this, we had reduced the defect significantly. So today, I read a lot of, I see a lot of presentations and papers that are recommending this one as a staging procedure before you do a conventional orthognathic surgery. This is something that is not there in my list of indications, but people are saying that when you have a significant defect, when it is a significant psychosocial concern in the late mixed dentition period, you could move the maxilla 6 or 8 millimeters and then do it as an intermediate or a staging procedure. And when growth is complete, all you have to do is your finishing LeFor-1 osteotomy for a few millimeter advancement. This is not something that we have practiced, but from this case that I demonstrated, it's probably something that we will be doing more often. All the cases that we have operated are after the growth is complete, but this is being recommended by others now, and I think it's a good option. So this is a milder case, a patient who had refused to undergo LeFor-1 advancement because his job involved speaking, and he did not want any bit of compromise as a result of a surgery that improved his appearance. And when we started doing this new procedure, we welcomed him and had a nice occlusal table for him with 2 implants on one side and another one on the other side with stable results. This was another patient who had a mild deformity. Neither did he have crowding, nor did he have a poor occlusal table, but specifically because speech was a concern, this was carried out. And then after getting the significant new bone formation, as you can see on the right side picture, he was then restored with the implants. We have some difficult cases here before I finish off. This was a girl, though had a mild appearing deformity. She had no premaxilla at all. And these are cases, unfortunately, we still see from time to time, and options are very difficult. Complex reconstruction using microvascular bone and soft tissue could be one of the options, but we went for something that was different, and we have done a few more cases like this. The prosthodontists do a temporary bridge in these cases with the teeth in the decompensated position, and like you see on the left hand side, and then we do a segmental distraction, bring the teeth forward with this temporary bridge or a fixed partial denture for the anteriors, and then restore the occlusal table with a few implants and implant restorations, and then finally do a definitive fixed partial denture like you see at the end. This is something that has been published as a case report, and our orthodontists believe that this is something that can be done much more effectively than opting for very complex restorations of the premaxilla. Complications, I've already alluded to a root damage that could happen if you're not careful. Also an incomplete osteotomy cut if you have not confirmed, and then you might come to grief as you start moving the bone a few days later. Post-operatively, once again, the most common one is the open bite, the counterclockwise rotation, because the hyrax is inferior to the palate, and the axis of rotation is in the premolar area. And the other one is, as I showed in one of the cases, that you do not achieve the desired movement, which can be a complication. So the most common one obviously is this developing open bite, which we do correct by using callus molding or heavy elastics to bring down the bite, and in most instances it does work. Relapse is something that we have seen. So once you create this new bone, if you don't have teeth on the palatal side or wherever else to move into the new bone, you must have a space maintainer. Like I said, the best option would be to do put in an implant and do an implant supported teeth or a denture. But where that is not possible, some kind of a space maintainer has to be given. There have been instances where we lost the patient for follow-up for months together, and they came back with relapse because this new bone was not loaded, and the adjacent teeth just migrated into them. So in conclusion, what I would like to say is that this is an elegant little tool that can help you do a simple osteotomy and get significant correction in sagittal maxillary deficiencies after cleft palate repair. But one important take-home message is that you need a good orthodontist, particularly to get the teeth into a nice alignment post distraction. Thank you.
All right, thank you so much. I am going to turn the audio on for our moderators.
Yeah, that was an excellent talk. We did get some questions. There actually were a couple that came on my chat that when I looked at the chat after I was jotting them down, that actually did not show up when I first went to it. So is there a way of putting them on? One question we just got asked from Dr. Choi is, what about vascular problems?
Yeah, so yeah, I can see that. We haven't had any vascular compromise with the segments. So on the palatal side, we do not elevate any soft tissue at all. Like I said, the interdental osteotomies are always blind. You feel the osteotome or your piezo coming through the bone. We haven't had that problem at all.
Another question we had from Dr. Mercatus was, and this, I would have this question too, do you have any problems with oral nasal fistula after distracting? And I would add to that, how do you time this with your alveolar cleft bone grafting? And what do you expect to have with the alveolar cleft bone grafting when you do this? How good does it have to be?
Thank you, Dr. Steinberg. As I said, in our series, we have always operated these children at the completion of growth. So the alveolar bone graft is already done. But there have been instances where there were small fistulas that were present at the time we started off, which ended up becoming slightly bigger. So what we would do is we would tackle that fistula if at all it develops. This happens even when we do expansion pre-surgically. So that is more common in our experience when before doing bone graft, when the orthodontist does a lateral or transverse expansion, oftentimes the fistulas which were not apparent become apparent or become bigger. So that is something we might occasionally see here, and depending on the site and the size and the vascularity of the surrounding tissue, we would either do a local flap or a tissue transfer like a tongue flap to correct them later. But those are few and far between. And since we are not doing this in the late mixed dentition period, it has no correlation to the alveolar bone graft. Most of these patients are already grafted.
And if they failed, would you regraft them before you did the procedure?
Yes, we would do that. Yes, we would do that.
We have a question from Dr. Zary.
Dr. Steinberg?
What about the, yeah.
If I may interrupt, for the sake of time, would it be okay if we moved on to the second presentation and then continued the Q&A at the end?
Oh, that's perfectly okay. Did I go out of order, or were we supposed to do it this way?
That is totally fine. We can just go ahead. Dr. Martinez, if you approve. Okay, thank you.
Mm-hmm.
All right, if we can go ahead and introduce the next presenter.
Okay. Good morning to everyone. It's a great pleasure to introduce you. Dr. Marilena Salgado is our maxillofacial surgeon. He's a chief of the department of Niño Morelense in Toluca, Mexico. He is a participant in collaboration with the scholarships from the AOMS and is the past president of Mexican Association of Oral Maxillofacial Surgeons. Welcome, doctor.
Thank you.
You have your space.
It's a children's hospital in Toluca, Mexico.
Okay.
Okay, good afternoon. I appreciate the opportunity to the AOMS to present to you some important points to consider in the primary surgery of the unilateral cleft lip and palate that can offer a good result and affect facial growth as little as possible. Our children's hospital is a center of reference in the comprehensive care of the cleft lip and palate patients in Mexico. We perform around 400 surgeries per year. The cleft lip and palate primary closure objectives is not only an adequate aesthetic results, but the development of the language, normal and good facial growth. When evaluating a child with cleft lip and palate, we must consider that this malformation is present from the 12th week in the embryonic life, and that this malformation has caused a division of the premaxilla and the nasal septum during fetal growth. Due to the non-union of the facial process, as well as the effect that the tongue hands of the palate, hence, when the patient is born, we can observe the anatomical alteration that the lip and nose is present. The anatomical features of the clefts are the deviation and short columella, the flattening of the alar cartilage and the abnormal insertion, size of the labial cleft and position of the premaxilla, displacement of the septum towards in the non-cleft side, inferior and posterior displacement of the lateral crura, asymmetric nostrils, short lip, and absence of the nasal floor. The treatment plan will be designed by analyzing the features of each cleft and of each patient. Presurgical orthopedics. Nasoalveolar molding, or NAM, are attachments made for the newborn with cleft lip and palate. The goal is to perform a tension-free lip closure and position the premaxilla and the nasal structure within a normal anatomical position. Physiologically, the nasal cartilage is more pliable to be molded by the residual effect of the estrogens provided by the mother. These estrogens stimulate the secretion of the proteoglycans and hyaluronic acid that allow the cartilage to be flexible. This flexibility of the cartilage is present in newborn, has a relaxation mechanism of the ligaments, cartilage, and connective tissue necessary to cross the birth canal. Since the controversy in the literature has to whether lip repair can restrict maxillary growth, pressure on the upper lip causes the maxillary teeth to tilt back, causing an anterior crossbite. Lip reconstruction can also reduce growth in the dentoalveolar segment and underdevelopment of the premaxilla. In our center, we perform cheiloplasty between the 3rd to 6 months of life. Cleft lip repair techniques are categorized in 3 schools. 1, closing in straight lines. 2, geometrics. And 3, rotation and advancement technique. Each surgeon has a preference for a specific technique, but the general principles of primary closure are creating a symmetrical height of the lip and the nostrils, produce a symmetrical lip volume, constitute the cleft side nostril equal to the non-cleft side, alignment of the orbicular oris muscle, adequate lip length, symmetry in the cupid's bow. Regardless the surgical technique, it is essential to identify the natural anatomic reference points in order to design our surgical technique based in these points. That way, we reduce to a minimal margin of error. Always have a pre-surgical front and baseline view. Personally, I use two techniques for the lip primary closure, which are Millar rotation and advancement technique with molar modification and the Fisher technique. After performing our design, the first incision is limited to the skin. After that, we remove only the skin covering the edge of the cleft and preserve the full thickness of the orbicularis muscle. The splitting of the muscle from the skin and the mucosa is essential, and the detachment of the orbicularis muscle on the anterior nasal spine should be minimal to maintain a centered columella. We perform an incision in the vestibular sulcus of the maxillary lateral segment, making a supraperiosteal dissection to detach the elevator muscle on the nasal ala and the fibers of the orbicularis that are attached into the piriform fossa and the vestibular sulcus. Performing in right dissection from the piriform fossa border all the way to the inferior turbinate placement. Allow the relaxation and releases the alar cartilage. The middle crura is dissected as well as the septum cartilage from the anterior nasal spine in order to correct the septal deviation. The alar cartilage is dissected in its lower portion to constitute a natural normal nostril. Although for many years the nose was untreated in primary lip surgery, thinking that nasal growth was at risk, reports in the literature confirm that we do not affect the nasal growth and that conforming it properly gives us an adequate breathing function that in the long run will help in facial growth. Proper release of the insertion of the alar cartilage allow a better rotation of the nasal wing. We begin by suturing the nasal floor in its posterior border, continuing anteriorly and ending with a symmetrical nostril creation. The closure of the mucosa always following the anatomical references of our original design, starting from the top on the mucocutaneous junction and the base of the columella, all the way to the vermilion. Muscle suturing always taking a full thickness portion of the muscle, following the anatomical reference. We make sure to take care of the skin using fine sutures like 7 to 8/0. An immediate postoperative frontal and base view should be taken, so you can always compare the before and after images to evaluate the symmetry of the lip as well as the nostril. It's essential to have a picture follow-up of our patients, not only for immediate postoperative results, but during their development to evaluate facial function and growth. Here are a couple of examples of the follow-up of these patients after primary lip surgery. Primary palate repair. In the literature, there are reports about the ideal timing and different techniques in the repair of the palate cleft. In our center, we perform this closure between 12 and 18 months of age in one stage. The palatoplastic goals are a hard and soft palate closure, natural recreation of the insertion of the soft palate muscles, creation of a dynamic soft palate that, along with the lateral and posterior pharyngeal walls, provide velopharyngeal competition, a normal facial growth. We use Bardak technique. The incision is made along the margin of the cleft in the nasal and palatal mucosa junction, and on the alveolar process margin, contouring up to the upper incisors level, and elevating this way to pedicles flaps. Of all quite importance to release the muscles of the posterior border of the palate, including the insertion on the posterior nasal spine, and perform an intravelar veloplasty with replacement on the levator muscle to offer a good velopharyngeal competition, and a soft palate closure in 3 layers. Avoid leaving denuded bone in the lateral wounds, since the scar can have a negative influence on the middle facial growth. It's important long-term control to each patient, evaluating his facial growth, aesthetic results, and adequate speech development. Listen to these patients. Thank you for your attention.
Thank you very much. Thank you. An excellent presentation, Dr. Maria Elisa Lopez Salgado. We have some questions. Let me see.
Pardon.
Nader Mekadis, how do you choose between different techniques of primary lip repair in the unilateral cleft lip? You have mentioned using different techniques.
I use Millar and use Fisher techniques.
Yeah, they are asking, how do you choose for every case?
¿Cómo escoge cuál de las técnicas utilizar? ¿Cuándo Millar, cuándo Fisher?
Okay, when I have a more short lip, long lip, I use Fisher. But when the lip is short, I use Millar technique.
Okay. Thank you. We have another question. In white cleft cases, sometimes it's hard not to leave the nude bone. Do you cover with this buccal fat or what do you do? We don't hear anything.
De nuevo, Cecilia, perdóname.
Sí,
pero no
cuando son hendiduras amplias, algunas veces es muy difícil no dejar hueso desnudo a los lados en las heridas, que si cubre estas heridas con grasa bucal o cómo hace para cubrir estas heridas y que el video final no se escuchó.
Nunca cubro las heridas de hueso desnudo.
I never use any kind of buccal fat to graft the denuded bone. She only uses suture in order to get the flaps together with the gums.
Because the dissection is supraperiosteal. I never have a bone. Exposed bone.
Habla de los paladares, maestra. En el paladar cuando deja hueso desnudo.
No, nunca dejo de hueso desnudo porque mi incisión es exactamente sobre la unión de la mucosa. Entonces eso me permite ganar 2 o 3 milímetros para no dejar hueso desnudo.
What she does is that she makes her lateral incision a little bit more lateral, maybe at the alveolar process, in order to have wider flaps, in order not to leave denuded bone at all. She never leaves denuded bone.
Okay, thank you very much. We have another question is, what's your recommendation for SARPE in cleft lip patients for transverse deficiency?
¿Dónde, perdón, doctor?
They're asking about SARPE.
I think that's for Dr. Kita, don't you think?
Yeah, maybe. Cover node areas with cleft. Sorry.
I think that question is for Dr. Kita.
Yeah, Dr. Kita, you can answer that.
Okay, yeah, I'm unmuted now. So we rarely ever do a surgically assisted rapid maxillary palatal expansion in cleft palates because expansion is possible without having to do a midline split or whatever because there's no bone there. So yes, we do that orthodontically.
Okay, thank you very much. There is another question for Dr. Lopez Salgado. How do you manage the alar cartilage in primary closure?
Doctora Cecia, le voy a pedir si lo traducimos, por favor.
Excelente. Pregunta que cómo... espérenme un segundito. ¿Cómo manejar?
Hear the question.
I lost the question. Let me see.
So the question was, how do you manage the alar cartilages in primary repair?
Yeah.
Thank you.
The nose, yeah.
¿Cómo es que usted maneja el despegamiento del cartílago alar nasal?
Desinserto primero la base del ala de la nariz.
I do detach the alar base nose, the alar of the base of the nose.
Libero todo el ala de la nariz hasta la base del cornete inferior.
And I release all the nasal base all the way to the inferior turbinate.
Y separo todo el cartílago de la fosa piriforme. Y esto
And
me
I
permite
split
rotarlo.
all the cartilage from the piriform fossa with a supraperiosteal dissection.
Y
as
eso
far
me
as we can.
permite rotar toda el ala.
And that is going to allow to the ala to rotate into the middle line to the columella.
Okay. Thank you very much. Dr. Steinberg, do you have any question for Dr. Lopez Salgado or Dr. Prismar?
No, I think that's pretty good. Impressive results by both. Actually, I do have one question, and it's going back to the distraction. Some of these patients, particularly with bilateral, have infraorbital rim deficiencies in addition to maxillary deficiency. And by bringing the maxilla, whether it's the anterior portion alone or the whole maxilla forward, you actually increase the appearance of deformity. How do you address that?
Yeah, we wouldn't use this as an option in those cases, but if you did, then you may have to augment the malar area.
Thank you.
I have also a question about the distraction. What is your experience in the relapse with in relation with this scar retraction?
Relapse of the maxilla, of the segment, So, where we have been able to maintain the space and load the bone, the relapse rate is very, very minimal. You might get a half a millimeter or 1 millimeter. Sometimes you have an edge-to-edge relation when you see them after 2 years. But where you do not restore them well for some reasons, then you get definitely relapse. As far as scar, I don't think that adds to the relapse. Distraction, conceptually, this is distraction histogenesis. Therefore, that's probably one of the advantages, but I can't prove it clinically, whether you're growing soft tissues. That's something which we don't know. We are just guessing there, but the relapse rates are much lesser than when you do a significant maxillary advancement.
Thank you very much. We already have a lot of congratulations for your presentation for Dr. Luis Lopez Salgado and Dr. Krishnan. A lot of congratulations for the presentation for all of the participants.
Thank you.
Any questions?
I can see a couple of more. Can I address them? There's one question from Dr. Nader, which says, any experience with tipping of teeth when you do distraction? Yes, this is something we have to be aware of, particularly when you're doing callus modulation. You think you're correcting the open bite by moving the callus that is still soft, but if you overdo it, the teeth will extrude out. Yes, as well as posterior teeth, migrating if you do not restore the space. Yes, it can happen. Tipping as well as bodily migration. The orthodontist has to be careful. Like I said, post-op orthodontics is extremely important in this case. I think there were a couple of others earlier. If you have time, I can go through that.
Okay.
This one is what do you do for transverse deficiency coexisting with horizontal deficiency? So our orthodontist tries to expand the maxilla, like I mentioned a little earlier, with whatever orthodontic methods that they can employ. So we don't address that surgically. Cases of failed ABG, like I mentioned to Professor Steinberg, we redo them. There's another one on, do you ever use a Hyrax device along with the Lepetit advancement mask? I have no experience with this. We have talked about oronasal fistula. There's another important question. How can you go with expansion or any treatment with such bad oral hygiene? Yeah, that's a problem that we face sometimes, but our orthodontist tries their best to correct that. There was another question before, is AMD indicated in cases of maxillary hyperplasia where the length of the maxilla, that is ANS to PNS, is normal? I don't think so. And invariably in cleft maxillas, we find that the sagittal length is shorter. So I don't think this is something that we need to worry about. I think we've got all of them done now.
Thank you very much. I have a question for Dr. Maria Luisa Salgado. Do you have experience with membranes of pallets in the use of, in the scars, in the palate surgery?
Lo va a traducir, no lo puede traducir.
Le digo, doctora, si tiene alguna experiencia en el uso de membranas de concentrado de plaquetas, o del doctor Anito o algo PRF para el manejo de las...
No tengo ninguna experiencia, Rodolfo. Nosotros realmente no, lo que comentaba yo en la respuesta, no nos queda denudado el hueso en la parte lateral.
We don't have any denuded bone in the lateral wounds.
Cuando cerramos la incisión la hago contorneando los dientes en la parte anterior.
When we do this, the incision is contouring the teeth on the anterior parts.
Tampoco me deja que tenga una hendidura del segmento alveolar grande. Durante el labio cierro todo el piso nasal hasta la parte anterior del piso nasal.
And that is because when I do the caloplasty, I do a suturing of the nasal floor all the way from the anterior part to the posterior part, so I'm not going to have a wide cleft while I'm doing the palatoplasty.
Y cuando cierro el paladar, lo cierro hasta esa parte anterior y eso evita que yo tenga una comunicación grande a nivel alveolar.
And that when I do this with the caloplasty, that's going to avoid for the child to have a wider cleft while doing the palatoplasty. Doctora, preguntaban si usted utilizaba algún tipo de material como gel foam o alguna estructura para limitar el sangrado en la palatoplastía. They were asking
normalmente solamente infiltramos previo a la cirugía, hacemos una infiltración de lidocaína con epinefrina y
prior to the surgery, epinephrine and lidocaine to the palatal muscles. That way we prevent the bleeding during the palatoplasty.
Thank you. We have two more questions to Dr. Maria Luisa Salgado. What is the incidence of fistula in the palatal fistula in your experience?
I have probably 5% of the patients with fistula in the union to soft palate to hard palate. In my experience, it's 20 years, and there are small fistulas in the union.
Okay, thank you. And there is another question: do you experience with the boomerang flap in primary lip repair?
No, I only closed the anterior floor of the nose. I never opened the bomber, and no dissection the bomber in the primary surgery of lip.
Thank you very much.
I may have missed it, but I would like both speakers to comment on the timing of the closure of hard and soft palate. I may have missed it. European model is to delay closure of the hard palate to prevent palatal constriction. In the United States, most are closed by a year to 18 months, both hard and soft palate. I was wondering what your positions are on that.
Los tiempos quirúrgicos de palatoplastía, ¿cuándo los hace para paladar duro y para paladar blando?
I close in one time, and normally between the 11 to 18 months old, and it's only one time, not in two times.
My experience is also similar. In fact, we are now trying to move into a protocol wherein we try and do both the lip and the palate together. So if the parents are willing to wait till 9 months of age, so we do our palates between 9 to 12 months. And if the parents are willing to wait, we do nasoalveolar molding like Dr. Salgado. So it's already about 5 to 6 months. So if they're willing to wait for another 3 months, we now do lip and palate together. But that is a choice if we are able to educate the parents that one GA with one general anesthesia, you close the palate and the lip together. That's what I prefer with a kind of logistics that we have to deal with. There is some literature that suggests that general anesthesia to infants is not a very good thing. So also the fact that you can reduce the morbidity, you can reduce the length of hospital stay, etc. This is a model that we are trying, but not always succeeding. But it's definitely one-stage repair of palate between 9 to 12 months.
Thank you very much. There another question to Dr. Lopez Salgado. Do you do pushback where you do a Bardak's palatoplasty?
No, I only make a veloplastic, intravelar veloplastic, because when you disinsert the muscle of the posterior border, you free the soft palate muscle, and you don't need made more long the palate. With this free the muscle, when you free the muscle, you can have a posterior close to the movement of the muscle of the palate is normal.
Thank you very much. Anybody have any questions?
I do have a question for Dr. Kita as well. Can I?
Right. Yeah.
Yes.
Hi, Dr. Kita. I wanted to ask you, what we do here, well, where I work, we use a Hyrex device, rotated Hyrex device, and then we use the Le Petit mask for anterior advancement in a Lefort 1 surgery. And we can move the maxilla forward as much as we want. Do you ever use that protocol?
No, I haven't. Yeah, I saw that question from you. No, we haven't used that. I have no experience with that.
Oh, okay.
When they use the face mask, it's without any surgery. So during the growth period, so as an early intervention.
There's an article written by Dr. Ortiz Monasterio that describes this technique, and it actually works very well. Because I've used what you showed us, and the tilt for the teeth, it's quite big. One of my patients lost at least one molar, so but I can see that your patients are quite the teeth are quite stable. They don't lose any teeth with your protocol.
Oh, when we do the maxillary protraction?
Yeah, do they lose any molars?
Yeah, I'm not aware of something like that happening. But I have to once again ask my orthodontist, but not that I'm aware of, no.
Thank you.
We have another question, the last one, I think so. We are on time. Dr. Lopez Salgado, they're asking, what is your experience or on your opinion about the minimal incision surgery in palate surgery?
Well, only when you have a very thin cleft, I make a minimal incision. Not when you have a normal palate, because it's a minimal incision but maximal dissection, and probably it's the same to take out the flaps, but I think it's only when you have a very small or very thin cleft.
Thank you very much. Also, I have to say congratulations for both presentations. Vinny, do you have something to say? Dr.
Yes, if we are all done with the Q&A portion, we can go ahead and conclude today's program. Thank you to our presenters and our moderators and all of our attendees. This has been another successful week for us, and we hope you enjoyed another IMS Stay Connected series, Cases and Conversations. Please note that our final program of this series will be next Monday, June 8th, and we also hope that you join us on June 5th, this Friday, for the IMS Virtual Conference in collaboration with OsteoScience Foundation. Thank you once again to everybody.
Thank you.
Thank you. Thank you very much.
Congratulations. Thank you very much.
Thank you. Bye-bye. Bye.
Bye.